Subscribe to our YouTube channel and press the bell icon to get the latest updates.
Good evening, everyone, and welcome to yet another edition of ThePrint's soft cover. The COVID pandemic has forced all of us to take a hard look at health system, at healthcare, and the way we deliver it. Discussions that were so far restricted to a limited audience and to very few participants have become more broad-based as the threat of a possible COVID third wave looms large and the devastation of the second wave is still fresh in our minds. My guest today, Dr. K Ellangovan, is uniquely placed to talk about this, having seen the health system from both sides, first as a doctor and then as an officer of the Indian Administrative Service. He deals with the health system and ways to make it better in great detail in his forthcoming book, Creating Value in Healthcare, published by Notion Press. Welcome, Dr. Ellangovan.
Okay.
Without further ado, we'll now unveil the book. So that is the book. If you can hold up your copy as well, sir.
Yes.
Yeah. So for anybody who's interested in making the Indian health system better, this book is a must read.
Thank you.
Dr. Ellangovan holds a Master of Surgery in Orthopedics and has been a practicing surgeon before he joined the Indian Administrative Service. He was also Principal Secretary Health in the Government of Kerala and Mission Director, National Health Mission Kerala. He has a PhD from IIT Madras for his research on performance dimensions in public hospitals. I have a lot of questions for you, sir, but if there are some opening remarks that you would want to make.
Sure. So first of all, let me thank ThePrint and you for taking this interest in my book, which is about a subject that is so important and relevant today. So thank you for that. Now, my opening remarks would be like this. Healthcare system, according to me, has been a neglected system in India for quite some time. When I say neglected, what does it mean? I wanted to say that the contribution of healthcare services to the economy is understated. In fact, even noted economists have been only counting on a sickness absenteeism that has affected the economy. But what is not being accounted so far is loss in productivity. An obviously healthy person, due to some innate or very subclinical disease, has reduced his productivity, has led to a huge reduction in the contribution to the economy. Therefore, when the governments and everyone talks about economic growth, healthcare system shall not be neglected. The second opening remark is that why is that healthcare is not looked into in such great detail? I mean, as you rightly pointed out, but for this COVID-19 pandemic, it would have been a matter of discussions only in select chambers, not in the civil society. In that sense, COVID has actually raised all these questions about the resilience of a healthcare system and what needs to be done. Now, the second point is that in the Western world, there is a term called politics of healthcare. What does it mean? It means that when substantial portion of public money is spent on healthcare, healthcare becomes a subject matter of political manifestos. It occupies a center stage as one of the crucial issues where the contesting political parties discuss about their views about healthcare. Unfortunately, in India, we spend less than 2% of the GDP. Therefore, it is not a matter of concern for many of the political parties so far. However, I must admit that of late, the government of India has taken very serious note of the contribution of health to the economy and have taken several measures. These are my two opening. Therefore, the disconnectedness between economic growth and healthcare system on one side. Second is, what is the expenditure government incurs on healthcare system to ensure that people at large are healthy, are the two cornerstones within which we can discuss today as to how to create value in healthcare.
Right. So actually, my first question is kind of a follow-up to what you just said. But this affects all of us, and many of us have asked these questions anytime we visited a government hospital. So why are government hospitals the way they are?
Well, government hospital, if you talk about government hospital, you must go back to Board's committee in 1946. Pre-independent India has appointed Sir Board to study a health system to cater to population health. Please recollect that Indian population was challenged by epidemics and endemics those days. So, the board committee, as after several rounds of discussion, has given a design. That design is based on the provision of services. A three-layered system was basically advocated. This primary care, secondary care, and then tertiary care. Now, today, one of the reasons why government hospitals are not seen to be effective and efficient is because this classification or this leveling of hospitals as per the services is not relevant today. One. Number two, as I said, health is a state subject. Several states are being affected by lack of funds. This is mainly due to the huge increase in the non-capital expenditure, mainly in salaries. Every time when the pay commission comes in, the state government finances are hugely stressed. So the amount of money left for spending in healthcare becomes less and less. Therefore, health has been as matter of concern because of low investments by successive government. When I said low investments, you can think of low technology or access to the care. Government hospitals today have a very unique problem of low accountability, poor technology, and not so free for service today. I am not for one blaming anyone. Why I am saying low technology? The technology in healthcare is advancing so fast. Today, the quality is almost wrongly connected with the technology. So, the hospitals in government setup will not imbibe those technology very early, unlike in the case of corporate hospitals. Second, in terms of accountability. Accountability is generally seen as very low in public sector undertakings, hospitals. The reason is very simple. The doctor-patient relationship in a public hospital is very different from a doctor-patient relationship in a corporate hospital. For instance, you may not see the same doctor second time when you go to public hospital.
Right.
You go on a day one, see a doctor, he'll prescribe a drug or investigation. When you go for a revisit, he may not be the right doctor or he may not be the doctor you're meeting. So the total change in the way doctor-patient relationship are evolving in, or rather evolved, is different from any other hospital where doctor-patient relationship is so stable. Number three is basically low investments. It's basically a mismatch between the load on the hospital and the services that can be provided. That mismatch itself contributes to low quality and very poor conditions of patients staying there. That leads to several complications like medical errors and etc. etc. Therefore, in a nutshell, successive governments and the state governments have done so much in healthcare, but still the demand and the need for healthcare system is so high that they are not able to match up this demand. That is where the critical loss in quality, loss in accountability, and the huge issue of affordability. In the book, I very clearly said, healthcare services are fragmented. You go to an hospital, you will not get an end-to-end service, for instance. Technically speaking, hospital should dispense the medicines also, as per the mandate. But drugs are routinely prescribed outside. Tests are routinely prescribed outside. Therefore, the patient goes in and out of the hospital and incurs a huge expenditure, leading to a huge pocket expenditure. That this is a nutshell about the government hospital status. Nevertheless, I must say that the resources available in government hospital are one of the best. My own experience as a secretary in health department, I have seen in Kerala Many complicated cases are referred to medical college hospitals because they see medical college has a huge resource of human resource. The quality is excellent. Infrastructure may not be good, but the experienced hands, those who have seen so many cases across their services, comes very handy while handling a complicated case. So you must give that also to the government hospitals.
Right. So I would have asked this question later on, but something you mentioned, you said that the doctor-patient relationship in the government hospital is not stable because patients keep coming back to different doctors, while elsewhere it's more stable. But many would also argue that it is the private sector that has basically led the steady erosion of doctor-patient trust. How does what is your take on that, and how does one restore that trust?
Very important sort of observation. Now, I should say this. In India, about 30 years back, we had a doctor-patient relationship that can be easily be termed as a trust model. Because a patient had a trust in doctors and everything went on good. No patient asked any questions to doctors. And doctors also used to treat or diagnose by intuitive method. Not much of investigations were ordered and no questions were asked, and by and large, patients also accepted the outcome. So trust model went on for a few decades. Now, what actually broke this model is huge increase in the cost of care contributed by the corporate hospitals. Now, what is done for a very few, say few thousand rupees in a public hospital would have costed several thousands of rupees in a corporate hospitals. I am not for one blaming the corporate hospitals are exploiting. What I am trying to say is the models are different. The huge capital investment in a corporate setup, it is investment. So what happens is the services are evaluated based on the investment. At that point, when a patient goes with some expectation of meeting the cost and he comes with a huge bill, the trust gets broken. One. Second important thing happens is outcomes. Now, a person going to a corporate hospital will expect certainly that everything should be all right. I'm paying for the services. I must get all right and I should go home quickly.
Right.
Unfortunately, the disease condition may not be so that any unfortunate event coming up in a corporate hospital is less accepted than in a general hospital setting. What happens now then? It's basically the asymmetry of information between the physician and the patient that leads to the erosion of trust. That is where because now doctors by and large, there is no institutional mechanism to educate patients in India. Now with the advent of huge internet system and sort of Google coming up as an immediate sort of answer to many doubts, but people are not institutionally educated about the disease problem. So I speak a lot about patient engagement in my book. So this patient engagement is an important element to build trust between the doctor and the patient and for the patient to accept the outcome. Therefore, I don't fully buy that it is the corporate setup that has actually eroded the doctor-patient relationship. Of course, they do have a part. Even in government setup, is because of different reasons in government setup that patients today feel that any adverse outcome is because of negligence of the doctor.
Right.
That is the finding,
Right.
or the sinking feeling.
Right. So how does one make healthcare affordable?
Yeah. In fact, one of the three things which I suggested in my book is about affordability. See, affordability is important because India is not a rich country. India is in a transition, a demographic transition, and our lifestyle changes, our increase in our disposable income, as all have altered our dietary habits, our sedentary nature of life, have actually predisposed quite a large chunk of our population to chronic diseases. Now, chronic disease means lifelong medications. Now, if it becomes a monthly expenditure to bear, Now, people in the lower middle class and in the very lower economic status feel actually the pinch. And it is these people who also form the bulk of the blue collar workers who are so important for economy. It is that sickness absenteeism of this sector is, these sections of the population, I was referring to in the beginning. So affordability is important. Now, how do you make it affordable? Let us see what are the reasons why a person incurs expenditure, even in government hospital for that matter. One, 60% of the cost is estimated to be due to the drugs or medicines. Remaining 30% is due to the diagnostic test ordered outside the government hospitals. 8 to 10% because of transportation cost or the alternate cost, so on, so on. Now, coming to the cost of drugs and medicines. When I was Health Secretary Kerala, we tried to introduce a generic drug. So, see, there are two types of molecules. One is a branded molecule, other is a generic molecule. When a new drug is introduced, it has a patent protection. It's called branded molecule till such time the patent period expires. Once the patent period expires, it becomes a generic molecule. There are two kinds of patents allowed in pharmaceutical. One is product patent, and other is the process patent. Now, many doctors believe that the newer molecule is more effective. They switch over to newer drugs, which are basically branded drugs. It's very expensive. The same molecule, if there is a molecule in the market, which is one company making branded, other one making generic, there's a huge difference of cost. Almost 1/10 or sometimes 1/20th of the cost of the branded is a generic molecule. Why in India we are not able to use generic drugs in the way one should be? Please understand that India is the largest exporter of generic molecules to developed nations, notably US. Why isn't that the same companies are not selling the generic molecules here? Again, reasons are very obvious. A same company sending a generic molecule to the United States sells a branded name in India. Now, this is where I wanted to come in and say a few examples of how other countries have tried to do this. Any insistence on use of generic medicine in Kerala at least has come with resistance. Now, the doctors came back and told me that if you are insisting on generic medicine, can you give us a guarantee that the quality of drug is good? If some untoward incidents happens, we will not be responsible because we are not sure of the quality. So that is where I wrote a paper in 2013 that investment in healthcare is not necessarily building hospitals and buying ambulances. It also means that you have to set up drug testing laboratories. How will you win over the confidence of the doctors? If they have to use a generic drug, they should be given the test labs and results saying that generic medicines are as good as any branded medicine. Once you win over their confidence, I think increasingly doctors will switch over to generic medicine, which will drastically reduce the cost of healthcare. Now, this should also be coupled with another legislative measure to make it we should make it through some legislation that any spurious drugs found in the market will be dealt very seriously. The punishment should be so severe, therefore it becomes a deterrent for companies who are not so careful about the quality. So that is so much about the generic drugs. So Thailand has introduced legislation to cover essential medicines very crucial medicines on the list of essential medicines, and they've been successful very, very great extent. Similarly in Brazil. So Thailand and Brazil are two countries which through a legislative measure has enlarged the list of essential drugs coming under the price control mechanisms. And there the
also has quite a good universal healthcare system.
Correct. It's all part of a system that comes up. So one is on the drugs and medicine. Second on the appliances and diagnostic tests. For diagnostic tests, as I said, when trust model was getting broken up, a new model of engagement came in called evidence-based model, where doctors are being increasingly challenged for taking decisions this way or that way. They have to rely on evidences. Therefore, evidences came in handy as a proof or in the court of law to defend their cases. As a result, what had happened is diagnosis has assumed a huge role than in the past, and every illnesses was actually investigated little more than what is required. This has actually increased the cost. Otherwise, I will explain mushrooming of MRI centers, CT scan centers in and around public hospitals in India. These are the places where people go and spend large amount of money. The third important element, although not very important compared to the first and second, is the opportunity cost for the attendant. Now, any admission in hospital actually dislocates the family. Fine, if somebody in upper middle class, they absorb this cost, but in the lower class, it's a loss of it is loss of wages. Their expenditure to stay, because we don't allow patient to stay in the hospital. Patient attendant. So affordability has got 3-4 major pillars. We have to do a legislative measure to introduce generic medicine. We have to develop a standard care pathways to show that investigation need not be done beyond what is required. And we must create infrastructure for patient attendants to stay with the patient, so that if we do this, the affordability will drastically improve. That's my take on this.
Right. So, is there an ideal model of healthcare for a country like India, where, as you mentioned right in the beginning, we have been chronically underspending in health? So what's the right model for us to, and we also have a sort of very ambitious goal of achieving UHC at some point. Is there an ideal model for us?
Well, we should develop an ideal model. My answer would be we should develop. Now, what is an ideal model? See, our society is so stratified in terms of economic industry. It is not a country where everybody is in a particular set of bracket of income generations. Now, I will just take 2 minutes to explain what is the 3 models available in the world today. One is an out and out government sponsored healthcare system, as in the UK, that is National Health System. The other extreme of the spectrum is the US model driven by insurance companies, where the state has no major role in giving healthcare services. It is for the employer and the individual to care for himself. In between is what is known as a hybrid model, which we see in the Scandinavian countries, in Australia, for instance, and in India. Now, what is important for India? Can we simply leave at the hybrid stage and say that, okay, we'll achieve, this is going to be ideal for us? Definitely not. To my mind, healthcare sector need not be regulated, but needs to be monitored. Before you start giving a solution for healthcare system, my thing would be regulate, because the regulation is not an actual good word for doctors. Monitor. Here I want to give an example of NHS. NHS Trust gives money to all NHS hospitals based on certain parameters. What is the parameter? Parameter is that every year NHS will announce or will publicize benchmarks. If any hospital achieving that benchmark, it is seen as efficient. If it is not achieving that particular benchmark result, it is seen as inefficient. Just to give an example. A person of myocardial infarction, are commonly called heart attack. If he goes to an hospital, the average time of admission is 3.5 days, for example. This is a national average. So any hospital which discharges the patient after making the proper treatment, less than 3.5 is seen as efficient, by and large. So there is a rating system, single star, double star, triple star. A triple star means the best performing, where money is given without any conditions, it's untied funds. The hospital society can decide where to spend the money. Whereas a single star rating hospital, it's tied. The apex or the country NHS Trust says, please spend here, please spend here. So a rating system has come in. My point is that India's problem in healthcare is that lack of information. We have data, but there is lack of information. So government should first set up a data analytics as a program, because healthcare is so important that new evidences keep coming every day. It is the new evidence that actually gives guidance for doctors. Today, we are depending heavily on Western evidences. So, health information analytics should be set up. They should publicize nationwide average data. They should rate the private hospitals. Then third important is government should become a buyer of services. You cannot, the more used, there is a very important finding that the moment you invest more in public health care, those services are cornered by a few who are politically strong and politically articulated or economically strong. It's very proved. So the more money you put in the public health care, the person last in the queue may not be the actual beneficiary. Somebody else may be beneficiaries. I have seen people coming to medical college to take MRI and go back to private hospital. The MRI here is cheaper.
Yeah.
So you can't avoid this. So therefore, what I'm saying is that government should not only become a service provider, should also become a service buyer. You should buy the best services in the private hospital and insure people. So the hybrid model here is a too complex model in India, where government is not only provider of services, it is also largest buyer of services, regulate the private sector, set national benchmarks, and keep a huge information analytics system in the country. Therefore, new evidences on the diseases affecting Indian population comes to the fore quickly, and we can achieve an efficient and effective healthcare system.
Mm-hmm. And how much do you think Ayushman Bharat takes us on that path?
Ayushman Bharat is a great initiative, which is a good starter. It's a good starter because before Ayushman Bharat, there is a program called RSBY, Rashtriya Swasthya Bima Yojana.
Yeah.
I have administered it in Kerala. Now, where very few conditions. See, one of the thing of RSBY and Ayushman Bharat is that it can take care of your secondary care. That is, it can cover basic healthcare costs. It can cover basic conditions. But where does the catastrophic health expenditure comes in? The catastrophic health expenditure is one where when a family sustains 40% of their annual family income on healthcare, is said to have suffered a catastrophic healthcare. This happens only in major critical conditions like cancer or a major debilitating diseases or accidents totally incapacitating a earning member of the family. So, does this scheme also protect them? Is something which you have to see, because a primary condition, secondary conditions are easy to cover. That's why I said India should become a largest buyer of services, not in the primary or secondary, but in tertiary care. In tertiary care is where people become impoverished. So Ayushman Bharat should also evolve in due course of time to have a segmentation in itself based on income group. It should also be a co-payment system. Everything free may not be really sort of working well. Ayushman Bharat should be made applicable even to the rich person, wherein you ask him to pay X portion of the money. So the government and the individual becomes the largest buyer of services. When you become the largest buyer of services, you can stipulate the standards. That is why in the US, the quality of care was been a subject of debate because it is a constant dialogue between insurance companies and the doctors' lobby. Right. Every time the doctors raise their salary or anything, the insurance companies also will say, do this condition. That is how, at least on record, they say the standard so-called care cycle is defined. So that any doctor who does any maneuvering outside this has to explain to insurance company that I did because of this.
Right. So we're running out of time. So this is my last question, and I'm tempted to ask you this because you've been an IAS officer and a doctor, and you've looked so hard at the health system. Many people often say that if you made ministers and bureaucrats compulsorily go to a government hospital and not go to a private hospital, because during COVID we saw all our ministers who fell ill. Eventually, all of them got themselves admitted in private hospitals. So what is your take on that? Do you think that's a good idea to better our government hospitals?
Yes, that's what I said.
Mm-hmm.
The reason why many people don't go is not because of not good doctors there. Infrastructure the infrastructure. For instance, the diagnostic setup, the system, that's what my book says. My book says, how do you shorten a patient sort of cycle in the hospital? See, patient would like to spend as little time as possible in the hospital. But are the services designed in that way in a government hospital? Definitely not. Because there's a huge queue. That is why people go to private hospital where the patient cycle is very small. You go in today and get out, do all the tests on the same day, see the doctor, do that. So unless it is a good idea to make ministers and bureaucrats go, but then if it's their individual choice to go elsewhere, can we make them? Can we make them to go there? No. The lies is that not only hardware.
When they're availing CGHS.
Yeah, see, that's a very important thing in CGHS. You're right. CGHS has evolved into a very, very friendly institution today. CGHS today never asks question. CGHS gives the same medicine what is prescribed by a doctor outside.
Right.
It was not the case 30 years back. So today, that much of improvement in CGHS has made bureaucrats and senior people in the government happy with the CGHS. That's what I'm saying. System should be flexible. It should also be effective. It cannot be simply flexible and not be effective. So government hospital needs to be strengthened, no doubt about it. And I say strengthened, quote and unquote, it is both hardware and software. Unless the software also improves, there is no one is going to go who otherwise has money to go to a private setup. Because ultimately it is the cycle, time.
Right.
When did I get in and when did I get out? This will determine whether hospital in future are going to be effective or not. My own theory is that hospital's structure is getting fragmented.
Right.
Hospitals will not be seen after 20 years or 10 years like what's seen today. A multi-specialization hospital may not be a thing after 10 years. Hospitals will disintegrate into centers of excellence and around a medical conditions. Around a medical condition, hospitals are likely to come. A diabetic hospital will have not only some diabetologist, it will have a diabetic surgeon, it will have a diabetic ophthalmologist, it will have a diabetic cardiologist. So every specialization will be wrapped around a medical condition, and that will be a center of excellence in future. So a multi-specialized general practitioners will be likely to go down, and we are going to see a new model of hospital coming up.
Right. That was it was a very interesting discussion. I had actually had many more questions for you, but we're running out of time. So I would tell all my viewers, please go and buy this book, especially if you have an interest in healthcare. This book, you must read this book. Thank you so much, Dr. Ellangovan, for speaking to us. Thank you.
Thank you so much for having me here. I hope I was able to answer some of your questions, and I'm very open for suggestions as well. I'll be very happy to answer to any of your viewers if they can send me an email or whatever it is. I'm very passionate about discussing this subject. Thank you.
Viewers can also comment under this YouTube link, and you can reply. That would also be possible.